Hi. So we are going to now do the rest of the two diuretics that we are left with. We've covered, just to recapitulate, we've covered the carbonic anhydrase inhibitors, we've covered the loop diuretics, we've covered the thiazides. So they're acting right starting from the proximal convoluted tubule, loop of Henle, and the third one is the distal convoluted tubule. Now we'll talk about this potassium sparing diuretics which acts at the end, that is at the collecting duct. So before I go on to that, they are of two types basically. So one we are calling them as aldosterone antagonist, and the other is called as renal epithelial sodium channel inhibitor. Okay? So we have these two. Now, aldosterone antagonist, we have spironolactone and we have eplerenone. Like a tongue twister it is, eplerenone. Okay, coming to the renal epithelial sodium channel inhibitors, we have amiloride and triamterene. And we prefer amiloride. So now what do they do? So if we see what happens in the collecting duct belly. So see the collecting duct consists of two cells, the principal cells and the intercalated cells. So let's talk about first the principal cells. Mein kya hota hai? Now these principal cells, they have, so we already done again before, the other special sodium channels hote hain yahan pe. They are the renal epithelial sodium channels. And what is their role? Whatever sodium gets delivered at the end, jitna bhi reabsorb hoke bach gaya, about 1-2% of sodium jo reh jata hai, that gets reabsorbed through these channels, epithelial channels. Okay? And then yahan pe we have the sodium potassium ATPase. So sodium is going to go out, 3 sodium and 2 potassium is going to come in. So this is one way. Okay? So it is reabsorbed here. So this was the role of renal epithelial channels. Now what is the role of aldosterone antagonist here? So what here happens is that we have in this area an aldosterone receptor present. Okay? Now aldosterone receptor जो present होता है, obviously that is meant for aldosterone to attach. और aldosterone कब attach करेगा? See, there is condition in your body. For example, there is decrease in the sodium levels in the body. Okay, decreased sodium levels in the body and decreased sodium is delivered in the kidneys. So macula densa is going to sense it. Okay, होएगा क्या? The renin, angiotensin, aldosterone gets stimulated. And this leads to formation of angiotensin 1, angiotensin 2 and also the formation of aldosterone. Or aldosterone is now released. And this aldosterone is going to attach to this aldosterone receptor present in the collecting duct. And what is the role of this aldosterone and the aldosterone complex? So when they combine together, they lead to formation of certain proteins, and that is aldosterone induced proteins. Aldosterone induced proteins. So what these proteins do? They are going to increase the activity of these sodium channels, the epithelial channels. So more sodium is going to be reabsorbed. That is one. So they are going to increase the activity. So even agar kuch inactive channels pade andar, it will activate them also. So it increase the activity of the sodium channels. It will try and increase the number of these sodium channels. So whatever channels are present here, suppose there are channels here, it will stimulate that it should go and attached here, so that more sodium can be absorbed back. That is number 2. Then number 3, this is increasing the number, so as well as the synthesis. So number increase ka matlab hai कि more channels are going to get attached here and more channels are going to be formed. That is the synthesis. So it does all these things. So ultimately it will enhance the function of the sodium channel. So more sodium will be taken in, and when more sodium is usually taken in by these drugs, there tends to be loss of potassium ions in exchange. So potassium ions and even hydrogen ions, okay, so they can be lost. They are lost rather because of this exchange. So this is happening normally. Now what happens when you give potassium potassium sparing diuretics? That means they are going to spare potassium. They are going to keep potassium inside. वो उसको बाहर जाने नहीं देंगे, वो उसको बचा के रखेंगे हमारी बॉडी में. So what do you do when you give these drugs? So let's go first to the simple. The renal epithelial channel inhibitor. What they are going to do? They are simply going to act on these channels and they are going to block these channels. So sodium is not going to be reabsorbed. And when sodium is not going to be reabsorbed, obviously potassium भी lose नहीं होगा. So potassium का level in the body high रहेगा. It will be retained in the body. It will not be lost in that case. ठीक है? And what happens if you give an aldosterone antagonist? जब aldosterone antagonist like spironolactone आप देते हो, so what will happen? It will, an antagonist is going to attach to the receptor, and it will not allow aldosterone to attach to the receptor. So nothing which aldosterone was going to do will happen. So there will be no activity, no increase in number, no increase in synthesis. So whatever it is doing, ये सारा जो काम है, जो इसका काम है, ये कम हो जाएगा. Again sodium reabsorb नहीं हो पाएगा अंदर, and potassium retain रहेगा, hydrogen retain रहेगा. So it leads to saving of potassium. So spares the potassium, it saves it inside the body. That's why they call us potassium sparing diuretics. Now as a diuretic, they're not very efficacious. You don't use them कि किसी को diuresis अगर हमने देना है तो आप ये दोगे. No, they are not very efficacious. They're moderately efficacious. So what you do there is that you use them with the other diuretics like loop diuretics or thiazide diuretics. Why? Because those diuretics, they tend to lose potassium. ठीक है, जब आप वो diuretics दोगे, there is hypokalemia with them, and if you want to prevent that hypokalemia, you mix them with a potassium sparing diuretic. So when you give them together, so patient will not have hypokalemia. So you mix them with some other, or you give it along with the other diuretic. So it can be used along with other diuretic. For example, you're giving it in hypertension, or you're giving it in CHF. ठीक है? And CHF में what is the role of aldosterone antagonist? Because you know that in aldosterone is also known to cause ventricular remodeling. ठीक है? So you refer to this term in my lecture on CHF. So what is this ventricular remodeling? How it is bad for your heart? It's going to change the architecture of the heart. So it is going to make it very weak. So because aldosterone is bad in the sense it's called as remodeling. So if you give an aldosterone antagonist, it helps the patient because it prevents the ventricular remodeling. So it is very good drug in CHF. Then certain, there are certain types of edemas like in nephrotic syndrome, like if nephrotic edema, cirrhotic edema. इसमें क्या होता है? There is increase in the aldosterone level in the body. So in that case also you can give aldosterone antagonist. Or patient has hypokalemia, ठीक है? So you can give this. Or there is a condition where there is increase in the aldosterone level in the body, which is called as Conn's syndrome. So again you can give spironolactone. Then amiloride, उसको specifically हम कहाँ use करते हैं? We use them in lithium induced diabetes insipidus. ये mostly यहाँ पे we use spironolactone or eplerenone. ठीक है? But this is for amiloride, lithium induced amilo. What happens when lithium, side effect is it causes, it acts on these channels, and there is, reabsorption of sodium also along with it in the same channel. यहाँ पे जब cause करता है, so there is a lot of fluid is going wasted, and sodium is, getting diluted inside. So lithium का side effect है, it it causes a condition like diabetes insipidus. So what you do, you give amiloride, it will block these channels, and lithium will also not be reabsorbed, and sodium is also not going to be reabsorbed. So that is how it functions in this case. Another thing to remember about spironolactone is spironolactone, that itself, it is very short acting drug, but जो इसका metabolite है, which is called as canrenone, it has a long half-life of around 17 hours. So that's how it becomes longer acting. Otherwise, it itself is a short acting. Then spironolactone has a lot of endocrine problems like gynecomastia, especially in the males, and drowsiness and all these things. So we prefer eplerenone, right? Because it doesn't have this condition. And जो इसमें drug interaction important जो हमें याद रखनी है, it is with the ACE inhibitor. So ACE inhibitors also cause retention of potassium in the body or hyperkalemia. तो अगर वो spironolactone के आप साथ दे रहे हो and you're not monitoring the levels, it can lead to dangerous hyperkalemia. So very very careful in case, because CHF patients में ACE inhibitors are the primary drug of choice. और उसमें कई बार आपको spironolactone देना पड़ सकता है. Normally हम otherwise नहीं देते. तो वहाँ पे आप small doses दोगे for short time and you will keep on monitoring the potassium levels. Otherwise it can lead to dangerous hyperkalemia. Patient will go into arrhythmias. Right? So this is about the potassium sparing diuretics. Now let's come to the last group of diuretics, and we have the osmotic diuretics. Osmotic diuretics like mannitol. It's important, like for a drug to be acting as an osmotic diuretic. What is important to know that this drug का खुद कोई effect नहीं होना. It should be inert. ठीक है? It should not be causing any action on its own. It should be freely filtered through the kidneys. It is freely filtered through the kidneys. It should not get reabsorbed back into the body. We don't want it. ठीक है? And definitely exert an osmotic pressure, which means that it tends to take water with it. So what are its effects in the body? It can have effect on the cell. अगर आप IV, we are giving it by IV route, and what it does to the plasma volume, extracellular fluid volume, it will increase the volume in the ECF. ठीक है? So जैसे अपने blood में दे दिया in the plasma, you are injecting it. So obviously there is a lot of mannitol here in the plasma. तो obviously जब ये it becomes concentrated, so it will pull water. Cells में से जो है ना, वो इसके अंदर in the plasma water आना शुरू हो जाता है. So it increases the ECF volume from the intracellular fluid starts coming out, because there is so much of concentrated fluid present outside because of mannitol. So it increases the ECF volume, and because it increases the volume of ECF, definitely it will increase the renal blood flow too. And as a blood flow बढ़ेगा, ठीक है, what it does, it gets filtered through the glomerulus. Now when it gets filtered through the glomerulus, ठीक है, ये mannitol है और ये PCT है, and then this is the loop of Henle, ठीक है, and then this is the DCT, and so on and so forth. It has action on 2 points. One, it acts on PCT, and one, it acts on the loop of Henle usually. Primary action is here at the loop of Henle. In the loop of Henle, this is a secondary action. Action क्या है? जो mannitol यहाँ पे है, concentrated है, ठीक है. So what will happen? Normally यहाँ से water reabsorb हो जाता है, and sodium भी साथ में reabsorb हो जाता है. तो mainly इसका action water पे है, because अंदर जब concentrated solution पड़ा है, so water जो है वो बाहर को हमारी बॉडी में reabsorb नहीं होगा. Water will go with it, because यहाँ पे concentration of water कम लग रहा है because of mannitol. So it will pull the water to go because of osmosis. Water खींचेगा. So water के साथ obviously the urine volume बढ़ेगा. And similarly what it does the same things here because, and gradually यहाँ पे क्या होता है, ठीक है, जब water ज़्यादा है, that's also moving, and sodium is also not getting reabsorbed, because क्या होता है, water बहुत ज़्यादा है तो sodium इसमें dilute हो जाता है. तो जब चीज़ डाइल्यूट होगी सो ऑब्वियसली इट विल नॉट बी रीअब्जॉर्ब, वो तो कॉन्सेंट्रेटेड से हाई टू लो कॉन्सेंट्रेशन जाती है चीज़, ठीक है. सो इवन द सोडियम इज नॉट गोइंग टू बी रीअब्जॉर्ब्ड, बट द इफेक्ट इज मोर लॉस ऑफ वाटर एंड स्लाइट लॉस ऑफ सोडियम. So दोनों चीजें हैं, but water loss is more with osmotic diuretics. That's the because of osmosis, because it is present there, it increases the concentration and therefore it will actually not allow the water to be reabsorbed. ठीक है. So what are its uses? So the primary use actually is in glaucoma. ठीक है. It can be again, it can pull the extracellular fluid. Then cerebral edema, it is going to shift the fluid from the cells or from the brain and the eye, but never to use them. Contraindication is hemorrhage, because then ulta effect, it will leak into the cells and it will pull more water into the cells because of the hemorrhage. Then in case of oliguria, okay, less urine, and for example in shock, it can increase the renal blood flow. Third, it can be also used in barbiturate poisoning, because it will increase its elimination, not allow it to reabsorb back into the body. Barbiturate poisoning, this is one of the ways. The only issue with this is in the body, because it can lead to hyponatremia. That's one problem with this drug. So this is about the osmotic diuretics. So we have done two diuretics today, potassium sparing and osmotic diuretics. So potassium sparing are they important, that is the spironolactone, eplerenone, and the renal channel inhibitors, epithelial channel, sodium channels, amiloride and triamterene. These are very important to remember, especially spironolactone aldosterone antagonist है, or they are the uses hypertension, CHF, hypokalemia, nephrotic edema, cirrhotic, aldosterone जहाँ पे बढ़ा हुआ है उसको कम करने के लिए, and amiloride का main use है lithium induced diabetes insipidus. Another important question is asked in the MCQs, the metabolite of spironolactone is canrenone. Contraindicated, rather not contraindicated, we can say that should they be used, should they not be used, and the best option usually होता है कि they are not used together, not preferred to be used together. Osmotic diuretics is mannitol, and mannitol is an inert one. It is freely filtered, not reabsorbed, has an osmotic pressure, so increases the ECF volume. Actions are mainly at the loop, also in the PCT, where it doesn't allow the water to be reabsorbed back into the body. So water रहेगा in the urine, volume बढ़ेगा, सोडियम भी थोड़ा बहुत absorb नहीं होके सोडियम भी बाहर निकल जाएगा. So mainly it is water and less of sodium. So with this we come to the end of the chapter on diuretics. We've done all the important diuretics. So just go through all these videos and then you go and read your books. So first you go to the videos and read the books. I'm sure it is going to be super easy for you to understand. So we meet in the next lecture. Till then, take care, study hard. Thank you so much.